Now moving on to our last topic in this section, that is the secondary injuries. What are secondary injuries? Because we need to understand it's not the bone which is fractured, it's the patient who has got some kind of an injury. So we'll be briefly discussing what are the other associated problems when the bone fracture occurs. So this could be, classical example is the patient was on a bike, he was hit by the car from the back, he slipped off, he fell on his left side and his head got stuck to the rail. So what else could be wrong? There could be associated head injury, there could be associated shoulder, pectoral girdle injury, there could be associated left side chest injury, there could be left side abdomen, kidney and visceral injuries, there could be pelvic acetabular injuries, there could be spinal injuries, and there could be associated fracture of the femur as well as knee dislocations maybe, and associated tibial fractures as well. Or his ankle may got caught up in some kind of spokes of the wheel, and there may be associated ankle injuries as well. So when we are looking at the trauma, we have to clearly see the mechanism of injury, what could else be wrong with the patient. So there could be thoracic injuries which may be associated as well, like fractured rib or sternum, injuries to the lung or the heart. They could always check for the respiratory function. We have gone through in the previous lectures as well regarding how to manage trauma, and again it always follows the ABC, the primary airway, breathing, circulation, then it is always the disability, and lastly the exposure. So if there is associated problems like pneumothorax, hemothorax, they are a part of the primary survey and they should be dealt first before the musculoskeletal injury. There could be spinal cord injury as well. Now, spinal cord injury and neurological injury comes in the disability or section D of it. Once the patient's airway and cervical spine is clear, then probably the breathing and circulation is clear, then we think of these, establishing whether the spinal cord and nerve roots are damaged or not, and baseline for the lateral comparison is actually taken. But if there is some degree of spinal cord injury, that is dealt in the section D of the ATLS. Now coming to other injuries, which could be pelvic or abdominal injuries as well. Pelvic injuries actually produce a lot of blood loss, and this may be a problem in case of circulation. A patient may be due in a shock, or in case of hemorrhage shock due to pelvic or acetabular trauma. So as of such, pelvic or acetabular trauma is not an emergency, but the shock which is produced by the pelvic and acetabulum is actually an emergency, and it should be dealt in circulation, section C of the ATLS. And usually these kind of associated visceral injuries, especially the genitourinary viscera, may be damaged as well. For example, we have to usually input and output monitoring, NGs and Follies is actually adjunct to the primary survey and usually passed. But if the patient is having a scrotal swelling, there's blood at the meatus, and usually there is abdominal swelling along with that as well, then probably urethra has got damaged as well. Then we may have to go for, instead of transurethral Follies, we may have to go for suprapubic catheterization of the patient. Like urethral or bladder injuries can be suspected and should be suspected, especially these associated abdominal or pelvic injuries as well. And we may have to go for retrograde urethrograms as well sometimes to assess the patency of the urethra. And if it's not patent, probably suprapubic catheterization is a way to go, for especially to monitor input and output of the patients. Then this could be pectoral girdle injuries. If the story I just told you, the patient fell on the left side, probably the first thing he hit was the pelvic, left pelvis, and the second was actually the left shoulder. So patient, there may be a polytrauma of the associated injuries as well. There could be fracture or dislocation around the pelvic girdle. There could be shoulder dislocations. There could be damage to the brachial plexus. There could be damage to large vessels, the neck of the base, especially if the neck is going the opposite direction and shoulder is going the other direction. There is massive kind of injury, and this could lead to upper or lower brachial trunks injury. There could be neurological vascular examination of the upper limb is essential, and we may eventually, once the primary survey is done, the secondary survey started is actually head to toe examination. And the secondary survey may also have to go for the x-rays of the pelvic girdle just to see there is not associated dislocation or there is no associated trauma to the pelvic or the pectoral girdle as well. Now coming to the closed fractures. The general treatment is the first consideration that treat the whole patient, not only the fracture. Now that is what we need to remember. If we had a trauma patient, the primary is through ATLS protocol. You secure the airway and cervical spine, then you come to the breathing and circulation, and then once there is no disability and there is no problem, then probably if this is an isolated deformity or if an isolated femur fracture, then probably once the patient is vitally stable, we can think of managing this musculoskeletal trauma or this closed fracture. Only once the primary survey is done and patient is considered stable and we have done the secondary survey and we know this the only problem we have, that is only. But if there are other associated problems, for example, the patient is having a pneumothorax or a hemothorax, then these are the life-threatening injuries. They need to be dealt first before dealing with the, let's say, shaft of femur fracture or shaft of tibia fracture. So what is the close? If it's an isolated long bone fracture, then the method is to basically go for manipulation, reduce it, splint it, and preserve the movement of it. The classical example is basically usually we go for splint, which could be in form of, if it's upper limb, it could be in form of coaptation splint. If it's lower limb, it could be in form of a back slab. That is just to preserve the bone in that direction so that minimal swelling occurs, minimal pain occurs, and then we can later on fix the bone in a case of emergency. Now that is the simple injunction is reduce, hold, and exercise. If the fracture was such that the probably conservative treatment was taken, that is POP was applied and patient had gone through a non-operative technique, a bone was actually reduced, then probably we have to go for it. Once we have reduced it, we hold it in form of POP, then we have to encourage the patient to do exercises and eventually initiate the partial weight bearing and then the complete weight bearing, because that will promote bone healing. Now, classification of closed injuries. Now, there is actually Castillo classification is usually for open, although there is Shireen classification for open fractures as well, but Castillo is mainly used for open fractures, and for the class of closed injuries, there is actually Shireen classification, which is mainly utilized. There are 4 subtypes. This is actually grade 0, 1, 2, and 3. Although there are 4 subtypes, grade 0 is simple fractures with little or no soft tissue injury. Grade 1 is actually fractures with superficial laceration. There's some degree of superficial bruise as well, along with the fracture, and bruising of skin and subcutaneous tissue. Grade 2 is more severe fracture with deep soft tissue contusion and swelling. And grade 3 is severe injury with marked soft tissue damage and threatened compartment syndrome. For example, there was a crush kind of injury, although there was not open injury, but this resulted in a massive crush of the soft tissues, which eventually leads to myonecrosis, rhabdomyolysis. Eventually, the edema of that area is so much that it may be threatening eventually into compartment syndrome, and distal neurovascular may be getting compromised. In this section, we have briefly gone through how to manage, what is the general management of the fractures. As I told you, we have to look at the secondary problems as well. The general management as per ATLS guidelines, that you go for airway, secure airway and cervical spine. Then you look at the breathing, you make it sure there is no life-threatening breathing problems such as pneumothorax, hemothorax, tension pneumothorax. If there is not there, then you look at the circulation. You make it sure the patient is not in a shock. If the patient is in shock, we have to treat the shock first rather than the acetabular or pelvic fractures. Then comes the disability. You have to see whether it is associated neurologic compromise or not as well. And then once that is done, we go for environment and exposure. That is the control. There is no patient does not go into some kind of hypothermia, and we can expose the patient for secondary injuries. When the patient is stable during the primary survey, then we move on to the secondary survey. The secondary survey is head-to-toe examination, and then we are looking at the musculoskeletal injuries, whether there is isolated shaft of femur or shaft of tibia fracture as well, or there is isolated radius or ulna fracture or not, and then whether humerus is fractured or not. In general, the treatment is reduce it, hold it, and move it. So how we reduce it? We reduce it under anesthesia could be in form of manipulation anesthesia can be done. So the fractured actually bones ends are reduced properly. then they can be held in form of either back slab or in form of POP. And if we have given POP and we want to treat it non-operatively, then we have to make it sure that the patient moves his or her limb initially, and then to partial weight bearing, and then to complete weight bearing for proper bone healing. That's all from this section. Thank you very much. Keep watching sqadia.com.